So let us talk about some of the basics involved in the management of a patient admitted with lower GI bleeding. And how do we prepare the patient for a colonoscopy? What endoscope will we use? And what are we supposed to do? So the first thing is to make sure that the patient has become hemodynamically stable and the hemoglobin is in good shape and has been cleared by cardiologists or other subspecialists if the patient has serious comorbid conditions. And once the patient is ready for the procedure, we place an order for colonoscopy. And when it comes to the ideal timing for colonoscopy, the outcomes have been shown to be good if you perform a colonoscopy within the first 24 hours, anywhere between 12 to 24 hours after the admission with GI bleeding. As you know, once the patient is in the hospital with GI bleeding or admitted with a GI bleeding, it takes time to resuscitate them and clean their colon before you could consider colonoscopy. As long as the patient is not exsanguinating and the patient's bleed has stopped or slowed down and you're able to resuscitate, uh, one should consider colonoscopy instead of any other option. The other option is interventional radiology with embolization, which we consider if the patient is unable to take the prep or you're not able to resuscitate the patient and this patient has been bleeding profusely and exsanguinating. In that case, we go for interventional radiology and embolization. Otherwise, majority of the patients benefit from emergent colonoscopy, which is normally done within the first 12 to 24 hours. When you do the procedure, you are looking for the different causes for lower GI bleeding. And the most common cause for painless hematochezia that requires admission to the hospital is diverticular bleeding. And next, angioectasias could also present with painless rectal bleeding. And one should not forget the possibility of hemorrhoidal bleeding, again, a cause for painless rectal bleeding. If the patient has pain and also has diarrhea, mucousy stools along with blood, consider the possibility of colitis. It could be inflammatory bowel disease, either ulcerative colitis or Crohn's colitis, or in an elderly patient or patient who has underlying cardiovascular disease, atrial fibrillation, etc., one should consider the possibility of ischemic colitis. If a patient has weight loss and some change in the bowels before he presents with hematochezia, consider the possibility of cancer that has bled and caused hematochezia. So we talked about diverticular bleed, angioectasia, hemorrhoidal bleeding, colitis, and cancer. Don't forget to ask if the patient has had a recent colonoscopy with a polypectomy, in which case you should consider the possibility of post-polypectomy bleeding. So these are all the things that we're going to go after and see if we could find the cause and if the lesion is amenable for endoscopic therapy. So when it comes to setting up the scope, which scope should you go for in a patient who comes in with lower GI bleeding? So you have access to different scopes, but the best scope or the preferred scope for a patient with lower GI bleeding is a scope with a channel of 3.2 to 3.7 millimeters in size, and this allows the larger channel allows us to clear the stool or residual clots, and also allows us to insert the various probes that are used for controlling the bleed. And these probes tend to be at least 10 French in size. So if you go with a smaller channel scope, you may have difficulty clearing the clots and having a good exam, and you may, once you find the source of bleeding, you may be at a disadvantage in controlling the bleeding. So pick up a scope with a larger channel, anywhere between 3.2 to 3.7 millimeters. When it comes to doing the colonoscopy, don't stop short in the cecum. Make an attempt to go into the terminal ileum so that you could see if the terminal ileum is clear. If it is clear and all you see is blood in the colon, you know that the source of bleeding is just coming from the colon. On the other hand, if you see blood, uh, make sure you try to go up as far as possible into the terminal ileum to see if there is bile above. If not, you have to consider the possibility of a bleeding source either coming from the small bowel or the upper GI tract. One should keep in mind that a little bit of blood in the terminal ileum could be refluxate from the colon. So something to keep in mind. So in summary, when it comes to setting up the endoscopy, uh, consider the following. Make sure the patient is hemodynamically stable, hemoglobin at a good level. Get the clearance from subspecialists if the patient has serious comorbid conditions, and do it when the patient is hemodynamically stable and the colon has been cleared of all the clots and stool. And try to do it within the first 12 to 24 hours after the admission, and use an adult colonoscope with a 3.2 to 3.7 millimeter channel, and try to get into the terminal ileum and figure out whether it is only a lower GI or a colonic bleed, or is the bleed coming from higher up. I hope this is helpful. Thank you.